Okay, for part 2 of Module 5 video presentation, we're going to talk about the care of the patients with lower gastrointestinal disorders. Appendicitis was actually talked about in the last video presentation, and this is just a review of it because it is kind of considered the lower portion of the GI tract because it does happen down around the colon, the appendix of the colon. And it's just an acute inflammation. It happens most often in younger adults, and it can lead to peritonitis, which can be a life-threatening situation. This is just a picture of McBurney's point. It's that area that between the anterior ischial spine and the umbilicus, and that is where the pain is typically found in their tender in that area at McBurney's point, because that is where the appendix is found. Just briefly going to talk about gastroenteritis, and this is just an inflammation of really the small bowel, and this is what's common, what people get commonly from a viral or bacterial infection. There's lots of different causes for it. There's a table on page 1270 that discusses the different types of viral gastroenteritis and bacterial gastroenteritis. E. coli is a common bacterial cause for it. Rotavirus is common in kids, and it's just basically where they get diarrhea, a very pronounced diarrhea, sometimes nausea and vomiting, decreased appetite. Typically leads to dehydration, which is the biggest problem, and the problem occurs when an elderly patient gets gastroenteritis or a small child, because they are the ones that are more delicate and can actually end up very, very sick from something. And that's typically because they get dehydrated quicker and they can't tolerate the dehydration as well. Especially a lot of times the elderly have already medical problems, so it can lead to a very, very ill patient. So the important thing with gastroenteritis in those patients that are at risk is dehydration and identifying the signs and symptoms of dehydration in them and getting it treated quickly. The signs and symptoms, are the dry, pale lips, poor skin turgor, extensive thirst. So just make sure that you're aware. A lot of times they can have a fever with this, which can make the dehydration even more profound. So fluid replacement is a treatment for gastroenteritis. They will increase their fluid intake by mouth if at all possible. And if it's not possible to get them hydrated enough with that, they will have to start an IV. And typically that is normal saline, or half normal saline is what they'll give them, just to kind of replace everything that's lost with their vomiting or diarrhea. Sometimes they can get a low potassium level. If somebody has a lot of diarrhea, it'll take their potassium out of their body as well, so sometimes we have to replace that. So just be aware of that, of how to treat someone with gastroenteritis. Drug therapy, really not a lot. You kind of have to let this run its course a lot of times, unless a certain bacteria is identified, and then they can treat that appropriately with antibiotics. The important thing is not to ever give them the antidiarrheal medications like Lamodal. Those medications will not allow the patient to expel the virus or the bacteria. We want them actually to continue to go. That way they can expel that from their body. They can get that germ out of their body. All right, in the next few slides, we're going to talk about ulcerative colitis and Crohn's disease. Very, very common, very similar disorders. They are both thought to be autoimmune or genetic in link. There's no real known cause, but like I said, they're thought to be an autoimmune. Very similar, and there's a couple of pictures in the next few slides that kind of help tell the difference. Ulcerative colitis is basically known to really manifest in the rectum and the rectosigmoid colon, so that's the lower part of the colon. And then as we'll look at And Crohn's disease can happen anywhere in the GI tract, and it tends to kind of skip around. So ulcerative colitis is areas of ulcerations in the lower part of the colon. It can cause profound diarrhea. It's usually diagnosed with a colonoscopy, which we haven't really talked about yet. Colonoscopy is where they take the scope through the rectum and view the large bowel. And it's sort of like it's an AGD, but at a different view. And this is the test that they use to look at the lower bowel. So prep for a colonoscopy is definitely MPO the entire day before the test, because the goal is to completely evacuate the bowel so that the practitioner can view the colon and view all the mucosa of the large colon. So they have to be MPO, and they have to drink a prep. It depends on the doctor exactly what the prep is, but it's typically go lightly. And that is something that it's usually a gallon, and they have to drink like a cup every hour for the day before to completely evacuate their bowel. Your book has a good table on page 1272. Talks about the differential features of ulcerative colitis and Crohn's disease. If you look, you can see that ulcerative colitis causes a pretty profound liquid stools daily, 10 to 20 liquid that can be bloody stools, because the ulcerations in the colon can cause bleeding. They typically don't need surgery with ulcerative colitis. It's usually treated with the autoimmune medications. Several different drugs can be used. There's aminosalicylates that are used commonly to treat UC. They have an anti-inflammatory effect for them. And then there's anti-diarrheal meds that can be used, and that's Lamodal maybe. So they will actually use the anti-diarrheal meds for the ulcerative colitis patient. Other meds, glucocorticoids such as prednisone, steroids, these are things that will decrease the inflammatory effects of ulcerative colitis. And again, that comes with all the side effects of steroids. Long-term steroid use can lead to osteoporosis, peptic ulcer disease, and that can alter their patient's blood sugars if they have diabetes. Let's see. Immunomodulators, again, those are drugs that are immunosuppressive. Those are things like Remicade, Humira, those drugs that you hear advertised a lot. Those are pretty effective drugs for ulcerative colitis, but a lot of the side effects with that is that it does immunosuppress the patient, so they're at risk for immunosuppression, and they need to report any signs of beginning infection and try to avoid large crowds or people who are sick. There's a great table on 1275 for medications. The sulfasalazine drugs, the mesalamine drugs, the Acecol, and Roesa drugs, and it just kind of talks about the usual dosage of those medications that are used to treat ulcerative colitis. Nutrition therapy is also something that they will use to treat a patient with ulcerative colitis. Sometimes they'll keep them NPO to let the bowel rest. They may have to be put on TPN, and that's that total parenteral nutrition, where they put nutrition in an IV. A large central line is what they have to put that through. And sometimes, because the patient is just so nutrition compromised from the extensive diarrhea, that they have to put them on nutrition through their veins to kind of keep their weight up. There's some foods they should also try to avoid when they are eating, and that is raw vegetables. Other high fiber foods can exacerbate it. Any kind of a GI stimulant like caffeine, nuts, corn, smoking, is something they should avoid as well because it is a GI stimulant. So anything that irritates the colon, it should be avoided. There are exacerbations and remissions of ulcerative colitis. So sometimes stress and diet can bring on the signs and symptoms of it. The diarrhea can increase the diarrhea. So the patient just needs to kind of have some information on how to try to keep the exacerbations at minimal. Okay, Crohn's disease is very similar to ulcerative colitis. It is an inflammation of the bowel, but this one can actually occur throughout the GI tract. It can occur in areas from the mouth all the way to the anus, and it kind of skips around a little bit more. It's a little less predictable than ulcerative colitis. It is thought to be another autoimmune cause. It does have exacerbations and remissions as well. And the signs and symptoms are very similar. They do have a lot of diarrhea, and they can have severe malabsorption of food just because of the constant diarrhea. And they can have bleeding from the inflammation. So a lot of different complications can occur with these patients. Sometimes it can develop into cancer. It is sort of a precancerous disorder if not taken care of well. The fissures from Crohn's disease is a little bit deeper than the ulcerations from ulcerative colitis. So what can happen is they can actually get something called a fistula, and that is where it creates an opening in the outside of the bowel. So these can become pretty complicated. The fistula can just open the bowel into the peritoneum, or it can cause an opening between two segments of the bowel. And basically what happens when that happens is that the fluid will leak out of that hole and can cause further complications. And a lot of times that requires surgery. Other complications that can occur is a bowel obstruction, which means that the bowel itself is completely obstructed by maybe the fistula, or maybe just by the large amount of inflammation and fissures. Usually signs and symptoms of Crohn's disease is a patient that is malnourished. They report a lot of diarrhea, abdominal pain, and sometimes they'll have a low-grade fever. The fistulas and the bowel obstruction can lead to peritonitis if not identified. So if you recall, peritonitis is pretty life-threatening disorder or condition. So it can lead to some life-threatening conditions if not managed well. Again, colonoscopy can be a tool used to diagnose Crohn's disease, and just make sure that you understand the prep and the post-op for colonoscopies. Again, they have to have a prep to evacuate their bowel, and then they're sedated during the procedure. So post-procedure, a big job is just to make sure that they wake up appropriately, and that then you can kind of make sure their airway it's not as important with this test because it doesn't involve the gag reflux. But again, you would just slowly reintroduce foods to make sure they're going to tolerate it. Drug therapy for Crohn's disease is very, very similar to that of ulcerative colitis. A lot of them are on the Remicade and the Humira. These are usually infusions that they have to get maybe once a month. It kind of depends on the patient, but they'll have to go to an outpatient infusion center to have them administered. I think the Humira is a newer one, and it actually can be given subcutaneous every other week. They could give it to themselves maybe, and so that would be a teaching tool that would need to be done to teach them how to give sub-Q injections. And just remember that those drugs do immunosuppress the patient, so they'll need to be taught about that. Glucocorticoids with your prednisone, the immune suppressors as well, and so you would just have to teach your patient about all the side effects of steroids. Nutrition therapy is very similar. They want to avoid things that are going to irritate their bowel. They are very commonly malnourished just because of the constant diarrhea and the malabsorption. Sometimes, again, these patients will end up on TPN. Just remember, these are administered through a central line. And anytime you ever stop a TPN line abruptly, you always want to monitor your patient for any signs and symptoms of hypoglycemia. Surgeries that can occur to treat Crohn's disease, usually it's for the fistulas. Like I said, if they have an opening in the tract of the GI system, that can lead to very severe complications. It can lead to peritonitis. So sometimes part of that bowel needs to be removed that has the fistula in it. It depends on where it is in the bowel, because it can lead to a patient requiring an ostomy. It could be permanent, could be temporary ostomies. So we'll look at the care of the ostomy in the next few slides. So it's just a picture that shows the areas and the differences. It kind of compares and contrasts ulcerative colitis with Crohn's disease. Just another picture that shows a visual of the differences. If you take a look at the Crohn's disease, you can see how these are more fissures here. And that's how they can cause the fistulas that can cause this to go ahead and open up here and cause an opening in the bowel. And then here you can look and see how this skips around to areas in the colon. It can go from anywhere from the mouth to the anus. Ulcerative colitis, if you take a look here, you can see where this is ulcerated instead of the fissures. So there is, when they go in with the colonoscopy, they can kind of see and call it what it is by determining what the mucosa of the colon looks like and exactly where it is. If it's more in the lower portion and it's just more of like an ulcerated area, they will call it ulcerative colitis. So just a visual picture for things that can cause a lower GI bleed. Of course, the ulcerative colitis, colon cancer, polyps, diverticulitis, which we're going to talk about here in a few minutes, and then, the ulcerative colitis, and of course the Crohn's disease as well. It's not listed here, but it's another cause. Rectal cancer, we're going to talk about shortly, and then the hemorrhoids are superficial varicose veins that can cause bleeding in the lower GI tract. This is going to cause diarrhea. It's going to cause dark stools. It could be obvious bleeding. It could be dark tarry stools, depending on how much of a bleed it is. Colorectal cancer, just look at this. This is a great picture as far as a visual of the areas of the colon where colorectal cancer occurs most frequently. If you notice down here in the lower part of the colon is the highest percentage. And what I want you to look at this picture and think about is if there's colon cancers in any area here, sometimes like if there's a tumor here, they're going to remove this part of the bowel. They might need to as far as surgery. And this is where they might have to put an ostomy in this area. So just think about anatomically if you've ever taken care of a patient that has an ostomy. Sometimes it's over on this side, sometimes it's over here. So depending on where the cancer or whatever, the ulcerative colitis or the fissure or anything like that occurs. So just think about your anatomy as far as ascending colon, transverse, descending. And just remember your small bowel lays in here and sometimes it connects here. So sometimes they'll put an ostomy in part of the lower bowel, which would be the ileum. Remember you have the jejunum, the duodenum, and the ileum, and just kind of where those would lay, because sometimes they will put an ostomy in there as well. So just think about your anatomy when you're thinking about what type of an ostomy the patient has. So colorectal cancer is a cancer that occurs, of course, and more in the lower part of the large bowel. It's typically an adenocarcinoma. They are known to sometimes arise from polyps that can be found in the colon, and that's why it's very highly recommended that patients older than 50 have colonoscopies to determine if they have any polyps. They will remove the polyps frequently if they're there to make sure that the patient does not have any risk for having colon cancer. If somebody's known to have polyps, they will do their colonoscopies more frequently to monitor them closely. Colorectal cancer can metastasize through the blood or lymph, or it can directly spread to the tissues. It can enlarge in the lumen, causing lots of different complications. A lot of times it can cause a obstructed bowel, can cause bleeding, malnutrition. It depends on how large the tumor grows. If it completely obstructs the bowel, it can lead to pretty significant complications. There's known to be a family genetic link to patients who are at risk for getting colon cancer. Especially if they have immediate family members that have had it, they're more likely to have it. Patients who have Crohn's disease or ulcerative colitis are at risk for getting colon cancer. Patients who are older than 50 years of age, it puts them at higher risk as well. There's also environmental factors. H. pylori can put a patient at risk. Smoking, drinking, obesity, physical inactivity as well puts a patient at risk. Patients are taught to monitor for any change in bowel habits or any blood in their stool. If they identify that, they're told to let their physician know right away, because it is a sign of colon cancer. So if anybody reports noticing any blood in their stool, they will be evaluated, especially if they're over 50, because they know that could put them at risk and might identify the fact they might have colon cancer. So this is a cancer, so treatment is going to depend on the stage of the cancer, where it is, if it's metastasized, things like that. They may get chemo and radiation. The big thing to identify is the fact that they might have to have part of their colon removed and might have to have a stoma or a colostomy. I'm going to move to the next slide for the picture to discuss that. This is just a review of the staging of colon cancer and just kind of let you know what each stage refers to. And again, stage 4 would be the most invasive metastasized stage of the cancer. So this picture is a visual of where they would put a colostomy depending on where the tumor is. So it's just important to know that there's different types of ostomies and they occur in different areas of the colon. So the big thing to think about with this is that for this one, the stool that comes from the colostomy is going to look different than this one. The stool in this one will be more formed because it's lower in the bowel. The stool that comes from this colostomy is going to be more liquidy because it hasn't had time to travel throughout the bowel normally. And then again, here's a small bowel in here, and any ostomy that occurs, a lot of times they'll do like an ileostomy, which is in the ileum here of the small bowel. The stool will be very loose coming from that area because the stool just has not had time to travel through the colon normally to form the stool. Colostomy care is very important. Normal appearance of the stoma is that it should be moist and red. Typically coming right out of surgery. If somebody just has one place, it's going to be a little bit more edematous and a little more red and that's just because it's brand new. And then over time, it will, the edema will go down and it still should be moist and red, but not quite as red. The important thing to know is when somebody comes out from surgery, you're going to monitor it for any kind of signs and symptoms of ischemia, which means it's not getting blood flow. So if it gets dark, pale, or dry looking, you need to notify the provider immediately because it could have lost blood flow. And that can happen sometimes due to complications of where they pull the bowel out through the opening in the abdominal wall. So taking care of this is going to be a little bit daunting for the patient. So they typically have a wound care nurse that comes, the wound ostomy nurse that comes and teaches them. It's very, very important that before the patient leaves the hospital that they change it themselves. That way we will be able to tell whether they're going to be able to do this or not, instead of us just showing them how they need to, before they leave the hospital, be changing it themselves. Because we need to make sure that they can take good care of it, because if they don't, they can really end up with complications as far as the skin around the wound or around the ostomy. We need to make sure that they understand how to empty their bag and take care, and be clean. And it also is important that we help them to kind of come to terms with the fact that they have a colostomy. It can be kind of detrimental to a patient who really, as far as their vanity and their social life, it makes them feel really, it can cause depression and social anxiety. So it's important to kind of help them work through that. Intestinal obstruction is just where there's something that actually obstructs. So when we talked about the anatomy of the GI system, that everything needs to move forward, and it's meant for everything to move forward. So if something blocks the movement of the materials forward, it can cause a backup. So basically, the contents accumulate at and above the area of the obstruction, and you could just kind of imagine how that could complicate things. What's going to happen is the patient's going to start vomiting. They're not going to have an appetite, and things are going to get blocked, and they're going to start to have, they're going to be uncomfortable. There's a great table on page 1255 that talks about the different signs and symptoms, the key features of small bowel and large bowel obstructions, because this can happen anywhere along the GI tract. Causes of it can be colon cancer, can be diverticulitis. Diverticulitis is an inflammation of the bowel caused by diverticuli, and these diverticuli can get, food can get down in them. They're like little pouches, and they can build up. The food builds up, and it can cause an obstruction. The patient will be severely uncomfortable. There'll be nausea, vomiting, and abdominal pain depending on where the obstruction is. The small bowel is going to cause more of an upper GI abdominal distension, and then the large bowel, just because where it is anatomically, is going to cause more of a lower abdominal distension. And of course, their bowel sounds are going to be very, very hypoactive. Depending on how complete the obstruction is going to determine treatment. Sometimes they need surgery. Sometimes they can place an NG tube to remove the contents above the obstruction, and that sort of helps the patient's comfort. Also, sometimes by doing this, if it's a partial occlusion, it can fix itself over time if they just let the bowel rest. And then you'll just have to think of, while you're taking care of this patient, of their nutrition management. They're going to have fluids, maybe TPN, to treat them, because as long as the bowel's obstructed, we can't put anything by mouth. So we're going to have to find other ways to give them their nutrition. That could be TPN, it could be IV fluids. And then they'll also have the NG tube to help remove any of the contents above the obstruction to help their comfort. These are pictures of the different types of obstruction that can occur. This one right here can actually fix itself if identified. That they can just put the patient as NPO, and then it can kind of work its way back out. This one is probably going to be a little bit more difficult to fix, and it could be more of a condition that's going to require a surgery to go in and maybe take this part out and reconnect them and to fix the obstruction. This is just a list of the surgical intervention that may be appropriate for an intestinal obstruction. Postoperatively, you're going to monitor the patient as far as pain, discomfort, bleeding from the site, watch the site. And then the other thing is their bowel sounds are going to be pretty hypoactive postoperatively. But one thing that we're going to watch for is that the return of bowel sounds within a day or two. And really monitor these patients for passing flatus, just for the return of their function of their bowel is going to be really important. And then to teach them to try to determine what caused the obstruction and maybe do some education to prevent it from happening again. Just a review of nasogastric tubes. Monitor for proper functioning frequently. Every time you go in the room, you're going to take a peek at it and make sure it's still where it was before. All these NG tubes have markings on them. Just monitor that it's still where it should be. Monitor what's coming out of it. If it suddenly has a lot of blood coming from it, you're going to notify the provider. You're going to mark, and measure the what's coming out of it. Make sure it's set up like it should be as ordered. Remember, it's typically a low wall suction, which is about 80 millimeters of mercury. And then just make sure you do mouth care for a patient if they're NPO with an NG, because their mouth can tend to get really dry. Hemorrhoids are just distended veins in the rectal region caused by increased abdominal pressure. Pregnancy, obesity are common causes of them. People who are large and sit for very long periods of time, it can cause the increased abdominal pressure that can cause the varicose veins in the rectal area. The most common signs and symptoms is bleeding, pressure, discomfort in that area. Preventing and treatment of this is usually pretty effective. Diets high in fiber is what they should have, so that they're not straining and putting more pressure on the area. And then there's lidocaine anesthetics, topical anesthetics. There's anti-inflammatory ointments that can be applied. But a lot of it is just teaching the patient about how to do the high fiber diets to promote regular bowels. You want to prevent constipation, because that's going to cause the pressure to increase in that area. Sitz bath are also treatments that they can use to help promote comfort. Sometimes the physician will order stool softeners as well to decrease any straining when they're having a bowel movement, which can complicate in this condition. Malabsorption syndrome is just a syndrome that can occur from all of the disorders that we talked about. Can be Crohn's, can be ulcerative colitis, but basically the patient is just unable to absorb the nutrients from their GI tract. Sometimes it's a genetic factor. It could be they lack certain enzymes that help break down the food that help them to be absorbed. Essentially what they need is they might end up with total parenteral nutrition, and just basically treating their nutrition deficiency is how this is treated. They might need different vitamins, supplements. Treating, if it's caused by a chronic diarrhea, treating the chronic diarrhea is going to be one of it. And in some of these, you can actually give the Lomotil, the anti-diarrheal medications. There's a good table on 1263. It talks about taking care of the skin of a patient with diarrhea. Just make sure they do good hygiene. They might need ointment to keep their rectal area protected from the constant diarrhea. So just think about things like that in the treatment. That concludes this portion of the video presentation for the lower GI disorders in Module 5.